Welcome to Module 2 of Inflammatory Arthritis and its treatments. In this module, we will look at the different types of inflammatory arthritis. My name is Carolyn Wiskin. I'm a clinical pharmacist at Charlton Health in Hamilton, Ontario. When we think about the different types of inflammatory arthritis, there are three: rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. In rheumatoid arthritis, we often see a symmetrical pattern where the inflammation that's happening in joints, say on the right hand, is also happening on the left. And the joints that are affected the most are the joints that are at the base of your fingers. We call these the metacarpal joints. And these joints here become highly inflamed. We commonly see the next joints being inflamed, but the last joints of the finger are not. So these joints might be large, as you can see in the picture, these next joints be large, but the tissue in between is normal. If I was to do a fist and these joints were inflamed, you wouldn't see any little valleys at all. They would all be filled in. In psoriatic arthritis, this can also affect joints that are in the hands, the feet, as well as other larger joints too, but it's not always symmetrical, and the joints involved can be different. So we do not see this first set of joints, the metacarpal joints, affected, but we do see the second and third joints of the finger affected. And this also would be the same for the toes. The other difference is that the tendons and ligaments that go in between the joints, so in here, the tendons and ligaments will also be inflamed. So the entire finger or an entire toe is swollen because it's not just the joints, it's the tendons and ligaments leading into the joints. And we would call that a sausage finger or a sausage toe. The actual medical term for that is dactylitis. You may have heard of that. Now, both rheumatoid arthritis and psoriatic arthritis, they can go other places. Certainly, the hips can be involved, the knees, the shoulders, the elbows, multiple places. But the patterning of how the inflammation starts outside the joint and then moving in, as we see in psoriatic arthritis, is different. The other thing, just by the name psoriatic, you think, do you have to have psoriasis? Well, actually, about 30% of people with psoriasis go on to develop this type of arthritis. However, there are people who may have this arthritis pattern, and the only skin involvement they have could be a little patch behind their ear, the size of a penny, or a little bit of scalp involvement, a little bit of pitting or little dents in their nails. That could be it. Or you could literally have the joint involvement and only a family history of psoriasis. So there's a lot of different variations that can occur. Ankylosing spondylitis starts in the base of the spine usually. And I'm going to show you with a model what that might look like. So if we take this spine, we'll see that here, and this is half of a spine, this part is really the edge of your hips, if you will. We call this the pelvic girdle. And so basically where the crest of this pelvic bone curves around to the last part of the spine, we call this joint the sacroiliac joint. Why? Because the iliac crest is this part of the pelvic bone where you put your hands on your hips, that's the rim. And where that comes around to meet this last bone of your spine, almost a shield type shape, this is called the sacrum. So the sacroiliac joint is this space in here. And that's the area that first becomes inflamed. Now that inflammation causes, again, a lot of stiffness. It can spread up to the neck area, and it can also go to other areas. But one of the most common places that people with ankylosing spondylitis experience pain beyond the spine is the Achilles tendon, which is why I've shown a picture of that tendon in the slide that you see. So 3 different types of inflammatory arthritis, all having slightly different properties, but there's also things that they have in common. So the 3 key features that all inflammatory arthritis has is, first of all, inflammation, as we mentioned. Second of it all, that inflammation over time can cause destruction, and that destruction can lead to functional disability that cannot be reversed.
And so really our goal when we identify this high inflammation is to get on treatments that stop its progression. There are several different areas that we look at when we identify somebody with an inflammatory arthritis. The first is, yes, is there evidence of inflammation? And we can see that evidence by looking at the tissue, the redness, the warmth, but we can also see inflammation when we do blood tests and look at levels of inflammatory markers. Morning stiffness is apparent in all three of these conditions. And one of the things with ankylosing spondylitis is that not only is that stiffness prevalent in the morning, but when sleeping at night, the pain can get quite bad if you don't get up, move, and limber up those joints a little bit, especially in that lower back. So middle of the night wakening is quite common with that condition. When we look for blood markers, not just the level of inflammation in the system, we measure inflammation through what's called CRP or ESR, and that can be elevated in all three conditions. But the other thing we look for in the blood is there a marker that would actually tell us, yes, there's a high likelihood that you have this condition? And in the case of rheumatoid arthritis, there is a blood marker called rheumatoid factor and another one called anti-CCP. These are actually antibodies that some people generate when they have this condition. However, there are people that have rheumatoid arthritis that don't have these markers. And because their blood, or what we call serology, is negative, these people are known as seronegative rheumatoid arthritis. In psoriatic arthritis, we don't have a marker at all. So if somebody is thinking, oh, you can't have an inflammatory arthritis that's immune driven because you don't have a marker, that's not true. In psoriatic arthritis, there isn't one. In ankylosing spondylitis, there is a marker, and it's called the HLA-B27. And we do see that in a large proportion of people with ankylosing spondylitis. But then there is a group that does not have this marker, and they would be called seronegative ankylosing spondylitis. If we looked at where these things start, as we saw in our previous slide, the most common location for rheumatoid arthritis to begin is the small joints of the hands or feet. In psoriatic arthritis, as mentioned, the tendons and ligaments is where the inflammation starts, and that's where they attach into the joints. And it could be the joints of the hands and feet, but we can also see it starting in our larger joints. And ankylosing spondylitis, the most common area for it to begin, as mentioned, is the lower spine. Symmetry in rheumatoid arthritis, yes, always symmetrical. In psoriatic arthritis, it could be one finger in one hand, it could be at one toe on the opposite side, and one elbow or a shoulder. It could be small joints, yes, but it could also be large. And it is usually not symmetrical, but in some cases can be. Ankylosing spondylitis is not symmetrical generally, but we do see in the lower back, you will have pain often in both sacroiliac joints. It's just that you may have one hip or one knee affected, one Achilles tendon and not another.
The impact of the excess inflammation that is made in the body when you have an autoimmune disease is more than what you can see and feel. So where we are worried about inflammation over the long term damaging our joints, even causing bone and joints to wear away or cause erosion that would maybe change the shape of a joint and the function of it, yes, we're very concerned about that in rheumatoid arthritis and psoriatic arthritis. And yes, we're very concerned in ankylosing spondylitis that if that inflammation continues over time, that within the spine, the little vertebrae can actually develop bony spurs that can grow up and cover the spongy disc that's in between the bone. And that can lead to the spine that it is solid and is damaged and not able to be flexible. So yes, we're very concerned about that, and that's why we want to get on early treatment. But we can't lose sight of the fact that we also have this inflammation that is impacting other areas. And one of those is our blood vessels. So there is a higher likelihood of cardiovascular disease, both heart attacks and strokes, if we don't treat this excess inflammation. We can also see that it can affect the lungs. In rheumatoid arthritis, we can see interstitial lung disease, and that can also occur in some of our other types of inflammatory arthritis as well. We know that people with rheumatoid especially do have an increased risk of osteoporosis when they have their condition. And when we treat properly and we have that inflammation level lowered, the risk of osteoporosis becomes that of a woman or man of the same age. So the other piece that you might be thinking about is, what is the burden of stress? Certainly when you are maybe not sleeping as well, you're in pain, perhaps some of the things that you enjoy doing you're having a hard time with, that really is a burden in itself. And that leads to exhaustion. And then we have changes with the eyes that can happen in some of our conditions. We see this more in AS, ankylosing spondylitis, and psoriatic arthritis, where we can get a uveitis, an inflammation of the eyes. So we want to look at not just the joints, what you feel, what you see, but look at the body as a whole and say, this is a condition we need to stop in its tracks. And thank goodness we do have the treatments that can do that.
There are different ways that we monitor disease activity to find out, is somebody, let's say, on treatment doing well and in a state of remission or low disease, or is someone flaring and we may need to change their treatment. And so the way that we monitor this is, number one, by a physical exam, where the rheumatologist is actually feeling the joints to see, is there inflammation evident? And we certainly see an inflammatory joint feel more squishy like a grape as there's excess fluid in there, and rather than feeling hard like an almond, which might be an osteoarthritic joint, not a joint affected by excess inflammation driven by the immune system. So you'll see that doctors will be counting all your joints as they analyze them, and they may be recording whether a joint is tender to touch or swollen when they look at it, and they'll record that on something called a homunculus, which you see as this stick figure, and X's and circles are marked in these different joints as they do an exam. And every time you come back, they're going to reassess this to see what changes have happened. We can do ultrasound, and a special one called a ultrasound with high-powered Doppler gives us even more of an indication of inflammation. X-rays can be done, MRIs, and then we look at blood work to see what is your level of the inflammatory chemicals CRP and ESR. You can have active disease, and these aren't always elevated, but them being really high is also a signal that your disease is active. And then there are health assessment questionnaires, things that you will fill out often in a doctor's office. In some cases, people do this online, but they're going to ask questions of you. What amount of time do you spend feeling stiff in the morning? How much pain do you have? Often on a score of, say, 0 to 10, with 10 being the most severe. Is your sleep impacted? Are your activities of daily living impacted? How about your ability to socialize with others, go out, have people into your home and entertain? And what about your ability to work outside the home? How are those being impacted by your arthritis? We have some specific scores that are used for people with ankylosing spondylitis, and that is called the BASDI. That stands for Bath, because this survey was developed in Bath, England at a conference. So it's called the Bath Ankylosing Spondylitis Disease Index. And then we have a DAS, which is just a disease activity score we often use for both rheumatoid arthritis and psoriatic arthritis. So expect that you will be doing these surveys over time, because it's a great way to look at your overall disease activity. And it's going to be a combination of the physical exam, the questionnaires, and the blood work that's really going to tell the story as to how well your condition is controlled and whether or not treatment changes need to happen.